Hello, my name is Karen, and I'm a nurse. I'm here to discuss medication reconciliation. Medication reconciliation, or MedRec, is the formal process of comparing your patient's medications to prior to admission, during their admission, and on their discharge. The learning objectives of this video are to help providers understand how to properly complete the MedRec process, to help providers understand what errors and patient harm can happen when MedRec is not done properly, and to integrate patient education as part of the MedRec process itself. Let's go through a scenario from start to finish. First, I need to collect some information to have with me. I need to have the pharmacy information system, or my PIP. I need to have any medication the patient would have brought in with them so I can compare that. I also need to bring or find the MAR from the previous facility if they were here as a transfer. The PIP printout gives us a 4-month history of medications filled at a community pharmacy here in Saskatchewan. It's important to know that the medications that are filled on that PIP are not necessarily accurate. 40% of medications prescribed to patients are not taken as they are intended. When you see your PIP and it is blank, it might be blank because you have a traveler that has filled a prescription prior to 4 months. If you have a corrections officer or a corrections inmate, if any samples have been given out from the physician's office or on any study drugs, the Saskatoon Cancer Agency Tuberculosis Clinic or STD clinic, any samples purchased over the internet, if there's any illicit drug use, our border cities from Lloydminster or Flin Flon, if there is any over-the-counter medications purchased from the patient, and any research drugs the patient has taken. It's important to know that they won't all show up on the PIP, and we have to know that the PIP is not the gospel truth. It's helpful to review your patient's medications from when they brought them in from coming from home. Sometimes the family will bring them in, or the patient. It'll come in the form of a bubble pack or pill bottles or inhalers. We will give them back to the family after we've reviewed them. If their actual medications are not at hand, their community pharmacy can be phoned. When calling a pharmacy, it's important that you speak directly with a pharmacist or a pharmacy technician and not a pharmacy assistant. The pharmacist or registered pharmacy technician can give you a better in-depth history about your patient's medications. It's important to ask them about a list of the current medications your patient is taking instead of an overall medication history. Thinking ahead in knowing what medication the patient was on at home at any point of admission, whether from this facility or the facility the patient was just transferred from, is critical information to know, because this information will allow me to complete that proper MedRec on discharge. Patients who are coming from another healthcare facility should have a medication administration record. It should already have been filled out. It will tell us all of their medications they are taking and when the last time they took them. It's really important, especially for the as-needed medications. The PIP printout and the best possible medication history is not redone. For patients who are coming as a transfer from another healthcare facility, it will have been done for you already. What you need to know is you will take that information, and that is used as a medication reconciliation on transfer. The following scenario contains some typical questions I would ask my patient and their family members when trying to complete a best possible medication history. I'd like to go through your medication administration record while you're here at the hospital. I want you to tell me what kind of medications you're on and how you take them.
Thank you.
Okay. I see it says you take Lasix 40 milligrams. Is that the accurate dose that you take? And how often do you take them at home?
I take Lasix 40 once a day.
Okay. Is it, what color is that tablet?
The color is yellow, and I should tell you I don't take the whole tablet. I cut it in half because if I take the whole one, I pee too much, and also I should let you know the doctor doesn't know.
Okay. Okay. Well, we'll just let him know that that's the dose that you're taking. Okay. Is there any other medications that you take at home that I need to know about that you can think of?
I guess I better tell you I've got a stash of Tylenol 3s at home that I take for a back injury that happened a few years ago.
Okay. When did you last take some Tylenol number 3s?
I took one 3 days ago, and I should tell you my family doctor doesn't know.
Okay, that's all right. That's okay. Is there any other medications that you take? Something maybe over the counter that you've purchased, herbal supplements, anything along that line?
Yes, I really like St. John wort
Mhm.
and hemp seed oil.
Okay. When did you last take those?
This morning after breakfast.
Okay. Do you know the dose of the tablets that you take?
No, I just take one
One a day.
a day out of each bottle.
Okay. The following key elements of the best possible medication history must be completed each and every time. The patient's height and weight, any allergies, and make note of the reaction to the medications you are allergic to, the dose, the route, and the frequency of each medication, the time and date of the last dose taken of each medication, and be sure to date and sign the bottom left of the form on all of the pages, not just the first page. As the nurse, I've completed my step. I've done the best possible medication history, but we're not done yet. The physician must complete the medication reconciliation process.
The nurse has done a wonderful job. It's now my task as a physician to reconcile each of the medications. I can now actually see what medications my patient was really taking at home. My next job is to decide what medications I want the patient to be on while they're in the hospital. Stop and note, a physician should never ever reconcile a patient's medications prior to the best possible medication history being taken by the nursing staff. This can lead to significant errors and possible harm to a patient. For each medication, the physician will choose either continue, change, stop, or hold. Any changes to medication or new medication should be written on the doctor's order form within the patient chart. The doctor will need to record the date and time and initial each and every page of the medication reconciliation form. Now I've completed the MedRec on admission. From here, I give this MedRec form to the unit clerk, or on some units, a nurse, for them to process the form.
Let's recap some important lessons so far. The nurse doing the best possible medication history is a detective. You cannot assume that patients take all medications as prescribed. As part of the BPMH, you may have to make an additional phone call or two, and ideally, the BPMH should be completed within the first 24 hours of admission, but we know this is sometimes delayed. Most importantly, rushing and making assumptions often leads to errors.
And by completing each part of the MedRec process properly, clearly and legibly, the nurse and I have both made patient care better and safer.
The pharmacist ensures that the MedRec process provides clear medication orders for the patient on admission. If there are any questions about the patient's medications from the BPMH or the completed MedRec on admission process, then the pharmacist follows up with the patient's nurse, the physician, and the patient and family.
The patient has completed their hospital stay and we are getting ready for discharge. As a physician, I will be asking for 3 pieces of information that I'll need, and I'll get those either from the nurse or the unit clerk. The PIP, which is on the chart, the medication administration record, which the nursing staff keep, and the MedRec on discharge form. Ideally, the MedRec on discharge should be on the chart because I've identified a pending discharge. I sit down and compare all 3 documents to reconcile the medications. I go through each medication to decide what to do. What is it I want the patient to be taking at home? What continues and what stops? And how should they be taking the medication? Remember, I ask myself which medications are the same prior to hospital admission, which are adjusted while they are in the hospital, and which medications are new while they're in the hospital. I also ask is there any risk that I'm sending the patient home with any medication that can be confused or misused with what medications the patient may already have in their home? This is a critical point of education with the patient. The MedRec at Discharge can be used as a very powerful but simple tool in communicating and writing in explicit instructions to the patient on the last page of the document. If printed legibly, you can give your patient very clear instruction. Surgical specialists who aren't usually prescribing can use this back page to simply write continue medications as before admission and see your family doctor in 1 to 2 weeks to review your prescriptions.
I will also help to educate my patient and family at the bedside to ensure that information is clear. In some cases, I might make additional notes on the MedRec form. They're going to be simple and clear, something like when their next blood tests are due or when their next follow-up appointment is. My notes should also be clear for the community pharmacist.
Clear information to the pharmacist will save unnecessary phone calls back to the discharging physician and prevent any delays in the patient getting the medications that they need.
The patient gets the original, which is their prescription, they take to their community pharmacist. Some units stamp the original to indicate this is your prescription. This prescription will supersede all previously written prescriptions. In cases where the hospital faxes the original MedRec directly to a community pharmacy to be filled, then the patient is only given a copy, stamped copy. The stamped copy, the patient gets one additional copy to take to a follow-up appointment with their doctor or nurse practitioner. This follow-up appointment should happen within 1 to 2 weeks. The follow-up appointment is very important because the discharging physician is often not their family doctor. We also send a copy to their primary care provider, and a final copy is left on their chart. All of us together, the nurse with our unit clerks, with our physicians and our pharmacists, we work with our patients and their families, and we work as a team.
We know that the medication reconciliation process can sometimes be complex and time-consuming. However, if done correctly, the medication reconciliation process can make care safer for patients.
And as a patient, I must take a responsibility for the medications that I'm taking. But I turn to the physician, I turn to the nurse and to the pharmacist to help guide me and educate me as to the correct usage of that medication to keep me safe.
So know that by completing the medication reconciliation process properly, you are preventing patient harm and making healthcare safer.